Your physician looks at your blood pressure reading, tilts the screen slightly in your direction, and nods with quiet satisfaction. Good numbers, he says. Right where we want you. And you walk out of that office feeling like you passed the test, like you did everything right, like your body is cooperating. But here's what nobody said out loud in that room. For a person in their 70s, a reading that looks textbook perfect on a standard chart may not be perfect at all. It may actually be the reason you grabbed the door frame last Tuesday morning when you stood up too fast. It may be what is behind that slow, heavy fog that sits on your thoughts before noon most days. And according to research published in one of the most respected medical journals in the world, it may be quietly working against you rather than for you. After 3 decades working in cardiovascular medicine, operating on hearts, studying the way the aging body manages pressure and circulation, I want to have the kind of honest conversation that rarely happens in a 15-minute appointment. Because the blood pressure target you have probably been chasing your entire adult life, the one your doctor checks against at every visit, may be the wrong number for the body you're living in right now. Let me start at the beginning because this matters and the history of it is not what most people assume. The standard most of us grew up hearing, the idea that healthy blood pressure means a reading around 120/80, did not emerge from decades of careful research conducted on older adults. It was not derived from long-term studies of people in their 70s and 80s, tracking what pressure ranges produce the best outcomes in aging bodies. The truth is considerably less reassuring than that origin story would suggest. That target was built primarily from studies of middle-aged adults, people in their 40s and 50s, with relatively young cardiovascular systems, flexible arteries, and physiology that respond to pressure the way medical textbooks describe. For that population, the logic was sound. Lower pressure means less mechanical stress on vessel walls. Less stress means fewer heart attacks and strokes. The reasoning was valid and the data supported it. The problem came when medicine took that number and applied it universally across every age group without adequately asking whether the rules change when the body does. For decades, that question was not seriously pursued. The target became a standard. The standard became a habit. And the habit became something that millions of older adults and their physicians now follow without ever questioning whether it was designed for them. It was not, and that distinction has real consequences. Here is what actually happens to your cardiovascular system as you move through your 60s and 70s. Your arteries, which in younger decades were supple and elastic, gradually stiffen. The elastic proteins that gave them their flexibility are slowly replaced by denser, less pliable tissue. The vessel walls lose their ability to expand and rebound with each heartbeat the way they once did. Think of the difference between a new rubber band, full of stretch and resilience, and one that has been left in a drawer for years, brittle, liable to snap if pushed too far. That stiffening is not a disease. It is biology. It happens to everyone, and it changes the pressure dynamics of the entire circulatory system. When arteries stiffen, the heart has to work harder to push blood through them. Resting pressure naturally rises as a result. That is part of why blood pressure tends to increase with age, even in otherwise healthy people who eat well, exercise, and take care of themselves. The body is compensating for the structural changes in its own vessels. And here is where it becomes critically important. Your body has pressure-sensing mechanisms built directly into the walls of your major arteries. These sensors monitor blood pressure in real time and trigger rapid adjustments when it shifts, particularly when you change position. When you stand up from a chair or rise from bed, gravity pulls blood toward the lower half of your body. Pressure momentarily drops in the vessels supplying your brain. In a younger person, those sensors detect the shift almost instantly and trigger compensatory responses that restore adequate circulation within a second or two. After 70, those sensors slow down. The response time lengthens. And if your resting blood pressure is already sitting at a low baseline because of medication, there is simply very little reserve left to work with when that postural drop occurs. The body cannot compensate fast enough because the starting point is already too close to the floor. That is not a theoretical concern. That is a physiological reality that plays out in real people's homes, every single morning, often without anyone ever connecting it to blood pressure. Have you felt lightheaded when you stood up quickly from the sofa? Have you steadied yourself against a wall or reached for a chair in the seconds after rising from bed? Have you had a brief moment of visual dimming or a floating sensation that passed before you could fully register it? These experiences are not simply what getting older feels like. They are information, and they deserve to be taken seriously. In 2019, a study that should have fundamentally changed how physicians discuss blood pressure with older patients was published in one of the most prominent medical journals in the world. It examined adults over 75 specifically, not theoretical models, not extrapolations from younger populations. Real older adults followed over time with measurable outcomes. What the researchers found ran directly counter to the prevailing clinical habit. For people in this age group, the systolic pressure range associated with the best outcomes, fewer hospitalizations, better preservation of cognitive function, lower overall mortality, was not 120. It was not 115. It was between 130 and 145. That range, which would make many physicians instinctively reach for the prescription pad, was actually where older bodies functioned best and lived longest. I want to be precise about what this means and what it does not. Uncontrolled high blood pressure, readings in the range of 160, 170, and above, remains dangerous at any age. Nobody is suggesting that hypertension is harmless or that pressure should be allowed to climb without limit. That is not the argument. The argument is more specific and more important than that. There is a lower boundary as well as an upper one. There is a range below which an older body cannot sustain adequate circulation to the organs that need it most, particularly the brain. And millions of older adults are currently being medicated past that lower boundary without anyone noticing, because the symptoms it produces are being attributed to something else entirely. The statistic that I find most difficult to set aside, even after many years of thinking about this, is the fall and fracture data. Adults over 75 who are treated aggressively to reach systolic targets below 120 face a 28% higher risk of serious falls and fractures compared to those maintained at higher targets. 28%. In a population where a single serious fall can mean a fractured hip, a head injury, emergency surgery, weeks of hospitalization, and for many people the beginning of a rapid and irreversible functional decline, that is not a small number. It is not a marginal risk buried in the fine print of a research paper. It is a clinically significant difference that is being created every day by medication that was prescribed with the best possible intentions. The painful irony embedded in this is worth sitting with for a moment. The medication is prescribed to protect the heart and prevent strokes. That is a legitimate and worthy goal. But when the dose is too high for that particular body, it drops pressure to a point where the brain is chronically undersupplied. And a brain that is chronically undersupplied produces dizziness, unsteadiness, impaired coordination. Those symptoms lead to falls. Falls at this age produce exactly the kind of traumatic injury that causes strokes, cardiac events, and death. The medicine intended to prevent the catastrophe creates the conditions for it. And the most difficult part of catching this pattern is that the fall does not happen in the clinic. It happens at home, in the early morning when the house is quiet and the lights are not yet on. A person rises from bed to use the bathroom. Their blood pressure drops 15 or 20 points before the pressure sensors in their arteries have had time to register and respond. They reach for the wall, but they do not reach in time. Nobody connects it to the medication prescribed 6 months ago. The incident goes into the record as a mechanical fall. The medication dose stays unchanged. The risk continues. Let me describe what is happening inside the body during those seconds, because understanding the mechanism changes how you interpret your own experience. Your brain is the most metabolically demanding organ in your body. It accounts for roughly 2% of your body weight, but requires approximately 20% of your total blood supply, delivered continuously without interruption. The moment that supply drops, even marginally, the brain begins signaling distress. In a younger person with elastic arteries and fast-responding pressure sensors, small drops are corrected almost before they begin. The system adjusts in a second, and you feel nothing. In a body past 70, the arteries are stiffer, the sensors are slower, and if the resting pressure is already at the low end of the range, there's almost no buffer left. When you stand and gravity redistributes blood toward your lower body, that momentary pressure drop in the cerebral vessels lasts longer than it should. Not long enough to cause you to faint, in most cases. Long enough to produce a few seconds of dizziness, a brief narrowing at the edges of your vision, a passing sense of unreality or lightness in the head. Long enough to affect your balance and your ability to react if your footing is uncertain. And here is the part that receives far too little attention in routine clinical care. That sequence of events, repeated every morning, repeated every time you stand up throughout the day, repeated across months and years, is not benign. Emerging research is increasingly connecting patterns of chronic, low-grade undersupply to the brain with accelerated cognitive decline in older adults. It is not a dramatic event. It is a slow erosion. The brain is not receiving what it needs consistently, and over time, that has consequences that extend well beyond momentary dizziness. So when someone says your numbers look beautiful, it is worth asking a follow-up question. Does your head feel beautiful too? There is a simple test you can perform at home, using nothing more than the blood pressure monitor you likely already own, that can tell you more about your real cardiovascular situation than a standard office visit. It is called the orthostatic blood pressure assessment, and it takes about 5 minutes. Lie flat on your bed or sofa and rest quietly for 5 full minutes. Not 30 seconds. 5 minutes. Do not speak. Do not check your phone. Simply rest. While you're still lying flat, take your blood pressure and write down both numbers. Then, without sitting up first, move directly from lying to standing the way you would naturally get out of bed in the morning. Immediately after standing, within 60 seconds, take your blood pressure again and write down both numbers. Now compare the two readings. If your systolic pressure, the top number, dropped by more than 20 points when you move from lying to standing, that is called orthostatic hypotension, and it is a meaningful red flag. That gap, that window of pressure deficit in the seconds after standing, is the period during which your brain is receiving less blood than it needs, during which your balance is most compromised, during which a fall is most likely to happen. A drop of 20 points or more means your body is not compensating fast enough. That is a conversation your physician needs to have with you. Write down those numbers. Bring that piece of paper to your next appointment and place it on the desk. That data is real. It is specific to your body, and it deserves to be part of the clinical decision about your medication. The evidence-based pressure ranges for older adults, which differ meaningfully from the universal standard most people have been given, break down this way based on current research. For adults between 65 and 74, a systolic reading of 130 to 140 is generally where the best outcomes occur. That is already higher than the standard target, and intentionally so. For adults between 75 and 84, the appropriate range shifts upward again to approximately 135 to 145, not lower, higher. For adults 85 and older, or for those with what clinicians call frailty, a combination of reduced muscle mass, history of falls, and multiple chronic conditions, the range may reasonably extend to 140 to 150 systolic. These are not reckless numbers. They are not a license to ignore blood pressure or allow it to climb without limit. They are protective ranges informed by the actual physiological needs of older bodies that reflect what the research says about where older adults function best and live longest. If your physician trained on older guidelines and has not updated their approach to reflect the evolving evidence, that does not make them a bad clinician. Medicine changes, and not all of those changes filter into daily practice as quickly as they should. What it does mean is that you have a role to play in making sure your care reflects what the science currently supports. Most people leave a physician appointment having said a fraction of what they wanted to. The visit felt rushed. They did not want to seem troublesome. They assumed the physician had everything in hand. But informed patients who ask specific questions and bring specific data, reliably receive more individualized and more appropriate care. That is not an opinion. It is consistent across the evidence on patient-physician communication. There are 3 questions worth bringing to your next appointment. The first is this: given my specific age and health profile, what is my individualized blood pressure target, and what evidence supports that particular number? Not a general reassurance that things look okay. A specific target with a specific rationale. The second question is, can we check for orthostatic hypotension at this visit, measuring my pressure both lying flat and after standing? That test takes 3 minutes in a clinical setting. Many physicians do not perform it routinely, but most would do so immediately if a patient requested it directly. The third question is it possible that any of my current symptoms, dizziness when standing, morning fatigue, slower thinking, could be related to my blood pressure medication dose rather than to aging or another cause? That third question opens a door that is often left closed by default. It gives the physician explicit permission to consider over-medication as a possibility and to evaluate it seriously rather than attributing symptoms to unrelated causes by default. You're not being demanding or unreasonable by asking these things. You're participating in your own care in exactly the way that produces the best outcomes. There is something I return to often when I think about what I have seen over 30 years in cardiovascular medicine. The amount of clinical effort devoted to perfecting a number on a monitor, to getting that systolic reading down to 118, to hitting the guideline target that was established for a different age group, is enormous. And the amount of attention devoted to what happens to that perfectly medicated patient at 6 in the morning in a dark hallway when their brain does not receive enough blood for several seconds is nowhere near proportionate to the risk it represents. The monitor shows an excellent reading. The patient stumbles getting out of bed. The patient moves through their mornings in a fog. The patient's thinking feels slower and heavier than it did 2 years ago. And because the number is good, nobody looks further. This is the gap that needs to be closed, not with alarm or with a rejection of medical guidance, but with a more complete and more honest conversation about what the evidence actually says about blood pressure in older bodies, what the targets should actually be, and what the symptoms of overtreatment actually look like. If you have been experiencing dizziness when you stand, unusual fatigue in the mornings, moments of cognitive haziness, or a sense that your thinking is not as quick or clear as it once was, these deserve to be evaluated with an open mind. They may be signs of normal aging. They may have other causes, but they may also be signs that a medication dose is working harder against you than for you, and that a simple, carefully managed adjustment, done in genuine partnership with a physician who understands the current evidence, could restore a quality of daily experience that you have been accepting the absence of for far too long. That possibility is worth a conversation, a test, a question asked at the next appointment. The next 10 years of your life may feel very different depending on whether that conversation happens or not. That is not a small thing. That is the whole thing. Everything shared here is grounded in current cardiovascular research and clinical experience, but it is general in nature and cannot substitute for the individualized guidance of a physician who knows your complete medical history, your current medications, and your specific situation. Bring this information into that relationship. Use it to ask better questions. Use it to make sure your care is built around the body you actually have at the age you are actually living, not around a number that was never designed with you in mind.